for having me. Yeah, thanks for such an awesome event, and thanks to Glenmark for having me. Yeah, I'm stuck in Cape Town actually. Well, not stuck. It's actually brilliant. I'm at the International Immunology Congress, which is brilliant, except for one of the items on the agenda I might have to cut short, and that's the discussion, unfortunately, because I have to meet with the management of the hotel at about 8:15 because I checked in on Monday, but I was too early, and my bag has gone somewhere around the world with one of the tour groups. So I've been living day to day here. And so, yeah, I do apologize about that. And I'm going to try to get to this as best as I can. But, yeah, thanks for having me. And I just wanted to say, so I sort of cut that diploma. I put it at a hold because I was fortunate enough now that I've started my master's with the Imperial College of London in allergology. So, yeah, learning a lot and still a lot to learn. But as we all know, the more you know you don't know. So I'm going to just do a brief overview. I know there's 50 slides, but I'm going to run through it quickly and specifically the first bit. So we're going to start with, and it's going to lead up to the new drugs that Glenmark have done. But as Glenmark do know, I'm a proud advocate for good medicine, and the drugs should fall in with good medicine, okay, which they've done, and they are up and coming. So what we're going to do is my screen won't move. Okay, I'll have to do it at the bottom. Okay. Has it changed? Is that fine?
Perfect.
Yeah, perfect. Okay, so the contents is that, yeah, we're just going to talk a bit about ocular allergies to warm up, and I'm going to briefly go over that because I realize there's a bit time is of the essence here. And then the biggest ones going through the overview of asthma and allergic rhinitis, and then the new additions to the family. So a tad about ocular allergies. Okay, so they are localized allergic reactions, okay? And they can be either the dominant allergic or, as we find most of the time, is actually present with rhinitis. Most of the time you'll see this, other than if you're an ophthalmologist, where we end up treating them independently, which is quite sad, which we should be working closely together. Okay, so like I say, it's not a single entity. Okay, and it includes different pathogenesis and hypersensitivity mechanisms. So at the moment, there's sort of, as we sit here, 15 to 20% of the world population is affected by some form of allergic disease. And I actually think it's more, as in, you see the World Health Organization sort of released a statement in the end of May saying that respiratory disease worldwide will get worse. And actually, by the end of sort of 2050, we predict that 45% of the world will have asthma, okay, at that stage. And that's not only allergic-based asthma, that's actually from environmental pollutants, okay? So, but ocular symptoms present sort of 40 to 60% of all allergic patients, and it really impacts their quality of life, okay? And so the data is quite difficult to interpret at the moment because there's very few isolated sort of studies just on ocular symptoms, because it always normally comes with nasal symptoms. So that's why it's difficult to separate when it comes to allergic disease, sort of allergic rhinoconjunctivitis. Okay, so if we're moving on, this is just a sort of a basic overview, just to give you an idea. And into ocular allergy and ocular non-allergic hypersensitivity. Okay, so in ocular allergy, which we're really going to focus on, well, briefly, is that, remember, in any allergic-based disease, everything is not IgE-based. We're so used to everything being IgE-based, and yes, it's the antibody of allergic disease, but we get a lot of non-IgE-based allergies in general, when we start looking at cell-mediated mechanisms, and I'm not going to go too deep into that, but just to know that whenever you're dividing allergies, you're always dividing into IgE and non-IgE-based, okay? So the important ones that we'll see is our seasonal and perennial allergic conjunctivitis, our VKCs, and our AKCs. Okay, and if we move on quickly, and I know I'm going to go through the ocular stuff quickly because I really want to get to the sort of the gist of this talk, which is the asthma and the rhinitis part because of time. But what I want to say here is that we must be aware that, you know, every person that just comes in with an itching eye, we can't just say that, oh, well, they've got allergic conjunctivitis. But, you know, allergic conjunctivitis has got a broad base. And I think we see a lot of kids, and I'm sure specifically kids really, and I know we do see adults, but, you know, we see a lot of neglected kids with a lot of ocular surface disruption, corneal disruption. And it's quite sad that we're getting to that stage where we are, you know, we're so focused on the nose, which rightfully so, and all other allergic diseases, but we forget about the eyes. It's like we're afraid. And I'm not, like I say to most of my patients, I'm a cowboy and I don't mess around with eyes, but I'm also not afraid to refer to an ophthalmologist. Okay, so we get this sort of the seasonal, the seasonal allergic rhinitis, and the perennial being all year round or persistent. They're both IgE mediated atopic diseases. So for those who don't know, atopic is this sort of inherited. It doesn't mean you are going to be allergic if you're atopic. It's this inherent genetic predisposition to develop allergic-based disease. Okay, a lot of swelling of the eyelids, follicles, and papules. Okay, and the one area we need to focus on here is the VKC group, you know, this vernal keratoconjunctivitis, because these patients really suffer, and that's got a sort of a mixed picture of IgE and non-IgE. Okay, normally starts in childhood. Okay, and one of the key features, you know, and I'm going to show you a picture now, is these Trantis dots that they develop, but ulcers and these vernal plaques, which we should not let our patients get to this stage. So the biggest areas that I wanted to just show you quickly on this is, you know, you see this is this giant papilla in picture B over here, and then the other area is that if we look at picture C, this is a classic diagnosis of transit dots or Trantis dots here, you know, at the limbal region there. And so we must be aware, don't be afraid to look at the eyes. Pick up the ophthalmoscope after you've done with your otoscope. Check every patient. Okay, so, you know, we shouldn't be messing around with the eyes, and it's actually, in an allergic-based disease, it's really avoidable pathology in this regard. Okay, so just a quick differential that I'm going to skip through this section quite quickly because there's quite a bit to go through. So just remember the differentials being dry eyes, subacute and chronic infections, okay, and inflammatory and autoimmune conditions. Okay, so remember things like lupus and Sjogren's disease also present, and there's sort of this overlapping, you know, now with the new findings in immunology going that, you know, a lot of the overlapping sort of autoimmune pathophysiology with allergic based pathology. Okay, and the investigations, okay, just like anything, and we'll go through this a bit later with the asthma and everything, but, you know, we're going to look at the IgE investigations with regards to the serum specific, the skin pricks, and the component resolved. Okay, and then when it comes to eyes, there's specific sort of systemic or systematically environmental sort of allergens that we can look at. Okay, and specific to our area. And so what we're going to, and then we're going to, you sort of highlight the non-IgE base. These are certain tests, and the one thing is cosmetics. That's what I just want to highlight quickly, specifically, you know, makeups and all these base, and you know the ladies really generally love it more, and you get these contact dermatitises around the eyes, and that's where we're going to get more delayed type reactions, and that's where we'll be looking at things like doing patch testing in these guys. Okay, so, and these are the specialized ocular, like I say, I'm going through this quickly because I really want to get to the gist of this talk. And so just a bit of a management strategy for eyes. Okay, just remember you want to just avoid all relevant allergens, which is quite difficult in our setting. Okay, it really is, and we'll get to that a bit later as well. But topical antihistamines, mast cell stabilizers, and double action drugs, which we'll talk a bit about later. try and avoid too many topical corticosteroids. I know it's quick and easy that, you know, the patient comes in and I apologize that we, you know, for name dropping it, but, you know, we're very quick to go, yo, Tobradex and all of these sort of things. But be careful of corticosteroids. We really don't always need them, okay? As well as the topical vasoconstrictors, okay? So, yeah, so, and then we can get to points of immunotherapy, which we will also allude to a bit later. And then in the non-IgE forms, just remember avoiding the specific triggers, you know, good hygiene, lubricants, and then it's very similar treatment. So it's sort of a one-size-fits-all when it comes to these, except we have these sort of the calcineurin inhibitors here. And then we can also use the systemic anti-allergic drugs in this regard, okay? And oopsie. So now we're going to get to, this is where I want to really get to. So asthma, and I know it sounds always simple, and we all think that, oh, we know how to manage every asthmatic patient, but it's surprising because with an incidence rate sort of 27 to 28 in the world, I think between 25 to 30th, we still have the top 5 highest fatality rates in the world, or morbidity rates. So we're obviously doing something wrong. It's a heterogeneous disease here, multiple phenotypes and chronic inflammation. Inflammation is very important, okay? Hyper-responsive airways, okay? And these guys, recurrent wheezing, breathlessness, chest tightness, and coughing, okay? And just remember the most important feature of asthma is its variable airflow obstruction. That is, can be either reversible spontaneously or with treatment. Okay, so this is just a quick picture of what a normal airway looks like here, what an asthmatic airway, that nice inflamed, thickened airway. And then this is what an asthmatic's airway looks like during the attack. And there's a lot of mucus going on there, and those airways are really, really narrowed. Okay. And the one thing I want to allude to is that, and I think the old sort of definition of going, well, we thought this was just a large airways sort of, but asthma is a disease of all the entire respiratory tract, from large, medium, small, you know, and that's very important, and very important when doing our lung functions. What I wanted to show you here is on a pathogenesis point of view, that is that it is a Th2 based type. So for those you don't know, that most of our inflammatory pathways, we've got these T helper cells. They follow a sort of a Th1, and allergic-based disease and parasitic follows a T helper 2. And this is where our eosinophils, our interleukin 4, 5, 13 come in. And this is what drives the inflammation in asthma. And this is where, when you start looking at new therapeutics, this is where biologics are coming in. You know, that's the new buzz now at the moment, where biologics are focusing on specific interleukin-based and targeted type of therapy. So we won't go too much into this, but it's an IgE mediated. Well, not quite. And you remember, asthma can be both allergic and non-allergic. Okay, and those that are allergic, often 80-90% IgE mediated. Okay, so the characteristics, as I've already alluded to, eosinophilic inflammation, okay? And the biggest cytokines being IL-4, 5, and 13, okay? It's both, you can get both IgE and non-IgE. Remember, every person that comes into your practice with wheezing isn't asthma, and every asthma is not allergic, okay? You get both allergic and non-allergic, okay? And from a young age, they get a lot of structural changes, remodeling, they cannot reverse this. It's irreversible loss of lung function from an early age. So we need to treat these patients properly and early, okay? And you'll see my last 2 comments actually alluding to the sort of under 5 age group, because we don't have a lot of studies in this group, you know, with regards to what is their long-term outcome, the bronchial thickening, the eosinophilic inflammation, okay? And so these are sort of preschool wheezes. This is a big topic on its own, and that's why GINA themselves have sort of, if you look in the guidelines, it's a difficult one to sort of give a treatment plan too. So it's almost like it's like an art. I find it's almost like managing diabetes. You just sort of have a, one size fits all. Yeah, okay. And like I said, the persistence of wheezing and progression to asthma results a complex relationship. It's between genetics, environmental exposures, and a lot of host genotypes. Okay, so risk factors for wheezing, just a quick one here. So our prenatal being maternal asthma, obesity, weight gain, smoking. Okay, and then our perinatal being cesarean section. Remember, cesarean section can increase allergic-based disease up to 5 times increased risk of allergic-based disease. Okay, genetics is specific genetic phenotypes, but I think as a sort of a general practitioner group and a general, we don't really need to. We'll leave these up to the smarter guys, And then postnatal, these two sort of viruses that have really increased the risk is the sort of RSV and rhinovirus, which they've linked. Okay, and then smoke exposure and then rapid weight gain. And so diagnostically, this is very important. If I have to just drill it in, is that we need to prove variability. We do get to the point where, and this will be more in adults, where you'll get a fixed airflow obstruction, but you would have generally had to have a long-standing history of chronic inflammatory disease from an asthmatic point of view. So if you've got a fixed airway obstruction in a child, you really got to think rethink your differential, okay? And like I said earlier, not every child who wheezes has asthma, and always look for associated risk factors, okay? Atopic disorders like allergic rhinitis, conjunctivitis, dermatitis, and then a family history. And this is where I might put my foot in it, is that I also find that what we're going to be careful of is, we always thought that, well, there has to be a family issue. No, well, you know what, genetic mutations are happening at a rapid rate. And I think in light of sort of westernization and the microbiomes and changes of the gut, I think we're going to see a lot of new firsts in the family. Okay. And so symptom onset of allergic-based asthma is normally in childhood, and then there's sort of identifiable triggers, exercise, environmental allergens, and so on and so forth. So the important part about this, just please, we should have peak flows in our practice. It is simple that we should be doing peak flows. Every asthmatic should know exactly what I'm still seeing asthmatics that have been 20 years in practice and don't even know what a peak flow is. We should be doing peak flows at every consultation, okay? And if you want to sort of confirm on original diagnosis, you want that peak flow of about 15% change, after sort of bronchodilation, where we use salbutamol. I like to use up to 400 mics salbutamol through a spacer. I don't think anyone should be using an MDR directly through the mouth, because the delivery of but the best technique is about 8 or 9% to the lungs. For me, that's sort of a bit useless. So when we're delivering to the space, we can have to 25 to 40% delivery to the lung, and we're going to get more accuracy. The FEV1s we can also use if you have spirometry or oscillometry in your practice of 12% post bronchodilation, and then this sort of diurnal variation, where we can sort of have these peak flow charts. And this is more so when we start looking at occupational asthma, the guy who's really battling during the work, or the lady who's battling Monday to Friday, and then on the weekend they're fine. So, make use of peak flow charts, and these are simple. These are, this is in the guideline of GINA. They're simple, and there are optional tests, which is quite nice. So we're doing full blood counts with eosinophil counts. We want to look at sort of more than 3% eosinophilias. And ideally, what we always go is, what we really want to prove, is this allergic-based disease or not? And so, and this is sort of where I'll contradict a bit as well, is that because I don't feel not everyone has skin prick, and then also I feel specific IgEs can be costly. And so I find that in the context of South Africa, that, it's great to do these, to say, okay, cool, we're going to have atopic disease, but also, not everyone's going to be sensitized to the environmental allergens in your wherever you're staying. Okay, so that's great to prove, but just by having a negative skin prick test or a specific IgE does not rule out having allergic based disease. And also we've got to be careful is that when we're doing these tests, how is it going to change our outcome at the end of the day? So I often go when I start doing this is, yes, it's great, it's nice, we're going to do our house dust mite and our cockroach and all that, but if we aren't planning right now, and I'm talking this from a practical approach, not from a sort of theoretical approach. A theoretical approach, you know, they like to do these, but from a practical approach, if we're going to sort of start looking at immunotherapies or desensitization, that's great, okay. And there's also sort of stress type of testing, histamine, methacholine, which is only done in our bigger academic centers. Exercise challenging is very easy in the practice. You run the little ones or the adults up to 6 minutes, and you can do that. And there's this big buzz now about nitric oxide testing, you know, pheno testing and changes, you know, more so in the biggest centers. And at the bottom here, I've really written about therapeutic trials, and this is sort of for the kids below the age of 5 years old. Okay, because, you know, this is sort of a diagnostic dilemma, and it becomes very tricky to diagnose these guys with asthma, and we mustn't just put that label. So, you know, if you aren't sure, there's nothing wrong with a therapeutic trial of inhaled corticosteroids over a 6 to 8 week period, but make sure we follow these patients up, okay? And it's just an image of spirometry and a peak flow here, and just eluding our differential. Remember, if you either you feel the treatment's not working, or you feel this is not, or this is the differential diagnosis of wheezing. Okay, so and I see a lot of it with regards to wheezes, and I see we treating a lot of asthmatics. As asthmatics, where I found their reactive wheezes actually because of an unmanaged allergic rhinitis or a chronic rhinosinusitis. And so if there's failed therapeutic trials, please, you know, rethink, go back to this differential. Okay. And another one is, I call them the mimickers of asthma or the wheezing patient, you know. GERD or gastroesophageal reflux disease is a common one. And in the setting of South Africa, we must never forget tuberculosis. Okay, this is a symptom. This is just sort of a severity assessment. So this is actually very controversial. I'm not a big fan of this because this is diagnostically, you know, at initial presentation, but it's quite difficult because this is actually should be used retrospectively. And I find that, you know, I'm not a big fan of this sort of classification. You'll see this sort of in the new GINA 2022-23 guidelines. You know, we don't really use too much, but if you want to get an idea of how or where you want to start in your treatment, this might not be a bad idea. But they've got brilliant sort of diagrams in the new GINA guidelines of where to start and how to start. But the thing at the end of the day, what you've got to remember is that we could have the severe persistent asthmatic, but can also respond to basic therapy. It doesn't mean they need to go straight to biologicals and everything else at the end of the day. That's why this is sort of a very controversial topic. Okay, so as you guys all know, this I'm sure has come up in many talks. You must just be aware of this. These are our adult-based tracks, and with regards to track A and track B, and it gets very sort of, you know, GINA just originally, obviously, we got this new buzz about RCS for Motril, which is great, but it doesn't mean, I mean, the ideal is we're trying to push towards the RCS for Motril base, you know, because when it comes to treatment, the one thing we need to remember is everyone's so confused about where to start, what to do. Treatment, think in your head, is about the risk of future reactions or asthma exacerbation. So if your patient is on a fluticasone salmeterol and is stable and doing well, there is also no need to change if there's no risk, you know, a low risk of future exacerbation. It's nice to follow track A when we can use that sort of as needed. And the reason why they've designed this is because it sort of came to a compliance point of view where they sort of decreased severe exacerbations, and that's only in the mild to moderate. So once we start getting to step 4, 5, it does not change the risk of exacerbation, whatever track you follow. So and coming to the sort of additional drugs we'll talk about just now, is that, yeah, so, you know, this is just the basic guideline of what we, and that's it. Like anything in medicine, it's a guideline. Obviously, Gina's trying to propose that we go to the RCS for Motril, if you can have that available in your setting. And you know, and it's just the smart therapy. For those who don't know, single maintenance and reliever therapy protocols, which is shown to treat these sort of modifiable risk factors. Okay, I've added the 6 to 11 year group, which, you know, I think will change soon. I feel should change, because, you know, everyone's a bit worried about drug dosing and that sort of thing. But I think we're going to start also going over to a smart, even though they are using it sort of step 3, 4. But the one thing we need to realize, everyone needs to realize, we are moving away, please. We are not using SABAs as reliever therapy on their own anymore. So whenever a SABA gets relieved, and this isn't an asthmatic, an allergic asthmatic, whenever a SABA or a reliever is needed to be used, we need to use an inhaled corticosteroid with it. And that is due to that if you're using a SABA on its own, we do not change the risk of asthma exacerbation at all. And increased SABA use actually increases the risk of fatality or death. So anyone of using sort of 3 meter dose, sort of 200 dose inhalers in here is a high risk. Okay, and the one thing we need to remember is that even the mild asthmatic, and this is very important, it's stated in the GINA guideline, the mild asthmatic still has a 30 to 40% chance of severe asthma exacerbation. Okay, so very important. We must be careful of telling our patients, oh, you know, you're just a mild asthmatic. It's not quite, because, and that's where the treatment, so if anyone didn't know that, it's all about the future risk. Okay, when we're treating asthmatics, it's about future risk. That's why we have the step guideline. Okay, it's not always how severe, because severe can be a retrospective. It's about what their future risk and what each of these steps hold in improving or decreasing that future risk. Okay, at the end of the day. Okay, we're going to move on to the last section, the rhinitis, which comes important with Salome's medication. Yeah, so just to know, rhinitis is allergic and non-allergic. Just remember, every rhinitis or hay fever that comes in is not every person who walks in with a rhinitis is allergic in nature. And but as we've seen here, there's a non-allergic base and allergic. So allergic being seasonal or perennial, and then the intermittent persistent. Okay, and so allergic rhinitis, it's, you know, I've got a big passion for allergic rhinitis, because I always think, you know, when did we forget about the nose? And I find that, and we must always remember the concept of sort of the united airway, you know, the nose and the lower respiratory tract. You know, we're so fixated that every wheezer that, and yes, we should be, but we're so fixated that a lot of my uncontrolled asthmatics is because they are uncontrolled rhinitises. You know, we're so quick, and they must use their inhalers, but, you know, oh, you know, they don't like the nasal spray or whatever it is. But you will find with the united airway concept, remember with allergic disease, and even, you know, you take a patient with eczema and who's sensitized to dust mite, if you put dust mite in their nasal passages, their skin will flare up. These are systemic disorders. This is Th2 driven systemic disorders. So think of it in that way. We must stop thinking of it in individual entities. So it's a symptomatic disorder of the nose. Okay, normally allergen, normally Ig mediated. Okay. And like I said, it's often trivialized, and we always just think it's a nuisance, but we don't spend enough time on this, okay? And the quality of life, I mean, people, and I'm sure you guys have seen it, and I call it's probably around from the 8th of August. If I could accurately say 2nd week of August, it's been an absolute nightmare. If I've got 5 patients well controlled on nasal therapy, including myself, that's impressive. And I've had 7 nasal surgeries already, and I've got sleep apnea. And so I've taken a beating this season. Okay, so the world prevalence between 10 to 40%, but I can tell you it's probably about 40%. Okay, and the Isaac studies have been done. So 20% in children in that age, and 67 and 40% in the 13 to 14-year-old group. And it's often associated with other allergic diseases and very common in the family history. But what we also got to realize now with sort of environmental toxins and pollutants is that I'm also starting to see a lot of non-allergic rhinitis at the moment. And I think we're going to go into an era of both allergic or mixed allergic and non-allergic rhinitis. Okay, so quick one, it's just basically rhinorrhea, clear rhinorrhea. Remember, a patient comes in with thick mucus plugging is generally not an allergic rhinitis patient. It's often infectious, or there's something else going on. Okay, congestion, nasal itching, postnasal drips. Okay, and then the nasal congestion is often one of the most troubling symptoms, specifically when it comes to sleep at nighttime. You know, patients can manage during the day, okay, but at nighttime. Okay, and then don't forget about hyposmia. You know, it's not only a COVID symptom, and then ocular symptoms. You know, we always forget, you know, even myself, I'm a bit nervous when it comes to eyes, but I'm also, you know, we need to pick up that ophthalmoscope and have a look in the eyes. Okay, and this is just a basic classification, you know, where the thing is that generally, if you have a true allergic rhinitis, and specifically in South Africa and the Eastern Cape, we don't really see too much seasonal. We've got persistent, you know, we've got perennial rhinitises. You know, our baselines are generally all terrible. It's just when the season changes, we notice it, okay, at the end of the day. But it's this intermittent and persistent type of classification in mild, moderate, severe at the end of the day. So just remember, you'll get this little one, or adult even, but I love this picture because I call this the puppy dog appearance. Child comes in, open mouth, gap between the teeth, beautiful allergic shyness, you know, and this is that classic atopic faces, you know, that you'll see. You know, you can often diagnose these, and if you want to be a really cool doctor, mom and dad are very impressed when you say across the table, geez, you can see obviously your child's battling with a blocked nose and so on and so forth. Obviously they say they don't, then obviously that but that doesn't happen too often. So especially if you see a child like this. The classic allergic salute. So remember, we get the nice, beautiful allergic salute that causes this nasal crease of the patients. Okay, these are just sort of mannerisms. And then on the examination, you get these shyness, like I said, there's thick skin folds that's under the eyes, the Denny Morgan lines. Okay, open mouth breathers. So remember that the dental malocclusion is very important. So children should not sleep with the mouth open. They should sleep with their mouth closed growing up, because that's where our tongue rests against the jaw. That's how our jaws form. That's why they get these elongated faces, because they're open mouth breathing, often having, you know. So it's not only about that early on in life. It's, you know, then you start, you know, I mean, our orthodontic colleagues, I mean, they'll appreciate it later when the children start getting braces at 13, 14, 15, you know, overlapping teeth and so on and so forth. But you know, it's very important, you know, just you can identify these patients across the room, and don't forget always to systematically ask about all the other conditions. Okay, this is just a picture of a turbinate, and why I wanted to show you that. If you look at the turbinate on the left, it's a beautifully pale turbinate. So an allergic turbinate is often quite pale, whereas when you get these infected patients, they're bright red, mucky red, mucoid-like type of turbinate. Okay, those are infectious, but the allergic patients have this pale, and it's normally the inferior turbinate. And you know, we often see the non-allergics in the middle, but there's no set in stone rule, but you'll often see that inferior turbinate that's pale. Okay, so that's what. And this is a nice grading system I like to use to tell, we'll chat to my patients, and they always find it quite exciting when you, so I use normal as sort of 0, and then moderate grade 1, severe grade 2, and obstructive grade 3. And they always find it, you know, sort of grade 2 or 3, you know, and they never forget that. So, and it's always quite nice when you follow them up that, you know, they see progress, you know, visual. We are human beings. We are sort of visually orientated. And you know, I bring this picture up on my computer. So, and it just, you know, if you do something properly the first time, you won't have to do it again. You won't get the patient with a compliance issue. I can tell you that for sure. Okay. And what I wanted to show you here with these guys, and just on a side note of these sort of grade 2 to 3 turbinates. Okay. So there's studies done on sort of REM sleep disorders. And, you know, for us to function, we sort of want to have a sort of 3 to 4 REM sleep cycles a night just to function as a human being the next day. And they've shown that with these grade 2 to 3 sort of turbinates, these guys go into 1 or 0. So they don't regenerate, or they don't rejuvenate serotonin and dopamine early hours of the morning. And these kids are tossing, turning, and then they rock up because, you know, I also found that, I mean, in East London specifically, I think it's things like ADD and anxiety has become sort of contagious almost. But, you know, you ask the parents and say, well, my child's up 3 times a night. I mean, we cannot do psychiatric assessment on a child that's 3 times a night awake because of a blocked nose. So we need to keep these things in mind. And it's actually shown, and I think in the American studies, they've shown snoring, if I'm not mistaken, sort of 3 to 6 months, you can actually decrease your long-term cognitive function. I think if it's snoring about 6 months, by 3 years, leading to early onset dementia, Alzheimer's, these are coming in. And I'm sneakily done a bit of a side study of my own. I've got 8 patients with grade 3, including myself. I've done sleep apnea studies. I've used specifically non-obese and non-alcoholics. And I mean, non-alcoholics, to do in sleep apnea studies. And none of us stop breathing less than 20 times an hour. Okay. And then those things can lead to things like hypertension, cardiac related issues, late onset obstructive airway disease without smoking. So just, you know, these are things to think about, you know, when talking about those. The nose is just not cool. You got a snot nose. It's not just about that. Okay. And so the diagnosis, just obviously history is very important. Okay. Clinical examination. And then, as I alluded to with the asthmatics as well, allergic sensitization, it's great. And it'd be nice if you have it at your disposal. That's great. But remember, sensitization, it's all about, remember with sensitization, and I always use sensitization. Remember an allergy test. Every test that comes back, and I don't like the term, but I'm going to use it now, positive does not mean you're allergic. It's called sensitization. Okay, remember, be careful. If you're testing an eczema patient, they sensitize, they class switch. So I've got patients who've got IgEs of greater than 100. The lab cannot, but they aren't allergic to those molecules. So be careful how we interpret these tests. And please just be careful of a cost effective. So it's nice to prove an allergic rhinitis, but I personally, and I mean, I'm just at the bottom of the food chain, and I think most people wouldn't, you know, beat you over the head if you've started this as a suspicion of allergic rhinitis and sort of at your review say, okay, maybe we can test. Be careful of batch testing. That's also what I want to say is that I get a bit frustrated this time of year. We're getting these patients with a phaidotop test. Everyone knows the phaidotop, the 5 common error allergens. If you do a phaidotop with a breakdown, that's a 3,500 Rand test for them to go on a nasal spray. Okay, so just think about it, you know, when you're testing. If it's coming to immunotherapies and those sort of things, that's great. Then you can plan in that regard, okay? And just remember, not all forms of rhinitis is allergic rhinitis, okay? Comorbidities, asthma, like I say, with rhinitis, up to 15 to 30% of your rhinitis patients will have asthma, and actually of your rhinitis patients, up to 60 to 75%. But in South Africa, I'm almost sure about 90% of asthmatics have rhinitis. I've got 2 patients in 6 years that I've only got an asthma inhalers, and I don't know how. Okay, and just think about all the other comorbidities, like I've been speaking about, the obstructive sleep apnea, the psychiatric disorders, and so on. Okay, this is a huge differential diagnosis which you're not going to go through, okay, of allergic rhinitis. But remember, if and when you're treating these patients, if they're not responding to therapy, take a step back and just, you know what, just open the differential diagnosis table. You can even Google this table. I can send you the slideshows. There are other things that call, and then just sort of rethink, you know, what we are treating here. Okay, so we're going to just quickly go over the treatment. Remember that the basics is education is always key, our non-drug treatment. So education, like we spoke about, allergen avoidance and environmental control. It's very nice to try your best to do that. So just remember that there's also things like dust mite pillows and sprays. There's no evidence for this, okay? They're costly and there's no real evidence. I mean, I know patients feel, because a lot of people don't want to use sort of steroid nose sprays and those sort of things, but they are very safe, okay? And even if you have the best, if you take your house and you take out all the carpets, put in tiled floors, you vacuum every day, wash the mattress every single day. And I'm not saying we should leave our house dirty, by the way, and the environment, and let a dog sleep on your face and so on and so forth. But what I'm saying is I'm alluding that drug treatment is very important. And I know patients don't want to hear this, but if you take your clothing every day and wash everything above 60 degrees, leave the mattress outside, you get about 9%, 9 or 10% improvement in a patient's allergies. Okay. So when we go to drug treatment, remember the most important treatment of true allergic rhinitis, intranasal corticosteroids. They're very safe. Most of our steroid nose sprays, except for beclomethasone, which I do not like, is most of them the absorption less than 0.5% into the body. Okay, and I like to tell my patients that, remember, they're always worried about long-term use of corticosteroids, but if I'm sure most of you will have received a patient that's been on an prednisolone or aspirone or prednisone. So remember, in 5 mils of prednisolone, it's 15 milligrams, 15,000 micrograms, absorption 80 to 90%. So you have to use a corticosteroid nose spray for about 20 years to match 1 day's dose of an oral steroid. So if you really want to try and convince your patients that that's sort of a good approach, okay? Our new combination nasal therapies, which are great, fortunately for Glenmark, and we'll chat about that. And then, as we see, these all add-on therapies, antihistamines, but remember, they're not, not ideal for monotherapies, and they're only used for mild AR and only for short term, okay? Our leukotrienes, our montelukast, chromones, I mean, sorry, it's a bit out of my time, so I haven't had the opportunity to use those anticholinergics. I use that for sort of, not in my allergics, but my vasomotor, sort of the allergic rhinitis in adults, actually, or geriatrics over the age of 75. Interesting enough, they don't really get massive turbiness, but they come in with this chronic postnasal drip. So we used to have a beautiful spray with a nasal adapter called Ipven. So what I do now, actually, I just take a saline bottle and I take some saline. You can actually use the entire and take out the salix, but to get this sort of same concentration, I use 4 ipratropiums and I put it into the salix. It treats a postnasal drip beautifully, okay, but obviously you got to watch for a rebound and a long term, okay. And then nasal irrigation, please never forget about nasal irrigation. Saline rinsing is, it's a great mechanism of flushing, and it also helps get our intranasal corticosteroids. Then decongestants, not a big fan. Remember, rebound or medicamentosa. And then systemic corticosteroids, I feel that, I know I've included, but even in acute flares, unless there's prominent otitis sort of medias or something, non-infectious, I try to stay away. Please stay away from injectable corticosteroids and all sorts of things like that. And then specific immunotherapy as well, okay. And then this is just a quick table on what has the effect on certain symptoms. So we're going to go through that. And then just quickly the drug treatment, as I have to get through this. Like I say, intranasal corticosteroids, the most effective class, very low adverse effects, then they're superior to anything else. Okay, and they are cost effective, and the importance is nasal spray technique. Please show your patients how to use a nasal spray. Very, very important. If they're not using it correctly, we're wasting their time and wasting their money, okay? This is just sort of the binding capacity, the bioavailability of this, and if anyone wants, we can definitely share these slides afterwards. And remember, nasal spray technique, sort of backwards, upwards, and out to the same eye. No sniffing. Please, no sniffing. If you sniff, 40% of the spray will end up in your throat. Remember, you can explain to your patients leaning a bit forward, spraying onto the terpene that's blocking the nose and leaning forward. If they do that, they'll have a bit of a runoff of about 8 or 9%. Okay, and that's about it. Okay, and oral antihistamines, they relieve the nasal and ocular symptoms, and they're very important for our rhinorrheas, our sneezing, and our itching, okay, and but they're not effective for congestion, okay. And remember, the new and the old generation, our old generations, they're very sedating. So our first generation, so we're trying to avoid those. And then we started sort of getting our second generation antihistamines, which are low sedating, and now the newer third generation antihistamines, which are just active metabolites of our second generation. And these are add-on therapies. Remember that we are not using these as monotherapies. Okay. And I just thought I'd put this slide in. Our third generation, we're going to look at sort of levocetirizine being that sort of an active metabolite of cetirizine, decreases the side effects and so on and so forth, and the effectivity of the drug, okay? And then the leukotrienes, they have mild decongesting effect, but less so than intranasal corticosteroids. And then similar to antihistamines, okay, and they are best used at nighttime. So remember, if you're prescribing leukotrienes, always best at nighttime, okay, and they are add-on therapies to our. It's part of our new guidelines of allergic rhinitis, the world guidelines. But remember, please never forget to tell your patients about black box warnings, mainly psychiatric-based symptoms, nightmares, agitation, aggression, those sort of things, okay. Otherwise, the parents won't be very happy with you, you know, when they come back. And it's a very good drug with comorbid disease of allergic rhinitis and asthma. Okay, so last bit I'm going to go through just quickly, leukotrienes and montelukast. Remember, leukotrienes, they're mast cell stabilizers. So the mast cell is one of the most important histamine-releasing cells, you know, part of our innate immune system. That's our first line defense. And they are secreted when you sort of get this antigen-antibody exposure. It's 1,000 times more potent inflammatory, okay, and montelukast is the drug that we use to stabilize, okay, these sort of mast cells, and they assist in the maintenance of asthma therapy, okay, and it does also help in allergic rhinitis, and it acts on the leukotriene receptors, okay. They are antagonists, okay, so they bind to the cysternal leukotriene receptor, both is in the lungs, but you get basically, and I don't want to go too in depth, but the LTD4s, there's also other LTDs, and I'm not going to go too in depth because I think that it's just, you know, it's not too important right now, and it helps sort of prevent this bronchial constriction and accumulation of mucus, etc. And last two slides just from a Glenmark, and we're very grateful that this drug has come out, this mometazone olipatidine molecule, you know, olipatidine being sort of an antihistaminergic, but it's also actually got its own bit of mast cell stabilizing, great drug combination therapy, but also be cautious because a lot of patients like it. And I know, I mean, Glenmark can shoot me for this, but I mean, I'm just saying that, you know, I think we must take this drug should be used for our moderate to severes, okay, and I think we should use this as our step up. I use it a lot also for seasonal flares, which has been great during the season, and then always I save it in my artillery for later, okay. And just to show, they've got a brilliant new drug at the moment, and I unfortunately haven't had the opportunity of using it, but I will be. So they've got this sort of the Glenmark molecule, which is the levocetirizine montelukast combination, and this can be used. I mean, they say, and the reason why I've done this talk is because I want us to think, even though the drug is promoted for you sort of seasonal allergic rhinitis, but just think about all the things we've spoken about with the eyes and the asthma. I mean, this can be part of long-term therapy, you know, and I'm sure that is in the pipeline, you know. Remember, and this drug is now sort of, well, it's approved from 18 years old, and I'm going to say from an off-label point of view that montelukast, I mean, at 10 milligrams. So they've got a 10 milligram and a 10 milligram montelukast with 5 levocetirizine, and we hope they will come out with other combinations soon. But, you know, a 10 milligram montelukast can, I'm just saying this indirectly, can sort of be used from 12 to 15, and levocetirizine is approved around the world from 12. But remember, the drug company is not saying this, but I'm just saying this indirectly. And I think this would be a great step-up therapy on top for our seasonal allergic rhinitis flares, and also just to use it. If you've got patients on combinations already, if you've got them on these individual molecules, why not use this? You know, and remember, this is not a, you know, this is not going to be a monotherapeutic molecule. It's often an add-on unless you're just treating the flares sometimes, which is a short-term use, okay? And so, you know, I know this has been a quick talk and everything, and I'm sorry I have to be heading out now. I can see they're calling me, but hopefully it's really I was sort of just giving you a quick overview, and please, I mean, also learn me that, I mean, you guys, you can take my number, and I'm still learning, you know, I'm still at the bottom of the food chain here, so I'm just learning, and you can take my email, and I'm always happy to help where I can. And yeah, thanks so much for having me, and I do apologize for taking your time. I hope you guys get some sleep tonight. Thank you.
Jason, thanks so much for that most insightful, informative, and I should also add high energy. So you have the gift of rapid speech, but very clear as well. So you covered a lot in a short space of time. I think we also appreciated the fact that you covered allergic rhinitis and asthma as well. So made it quite comprehensive.
Yeah.
So I think I'm just going to maybe stop